Great, thank you very much for that introduction. And I think Alice was talking about how sucrose is one of the worst things, right? But so is sedentary lifestyle, and we've been sitting all day. So everybody, I mean, I don't want everybody to fall asleep. Please, just raise your hands up and stretch a little bit. I was so tired all morning. Okay, thank you very much. Okay, great. Thank you. So as it is, I love this topic. I've been working on care transitions for about a decade now, and it's really, really great to see the Roundtable take it up. There's so many problems with it, but one of the goals really in the end is to get to a place where you have shared meaning between the clinicians and the patient and their families, and it's very hard. I'll give you one example of a real disaster of failed shared meeting I had with a young couple came in. I was talking with them about birth control options. I gave them a whole talking to about sharing responsibility. It shouldn't just be her responsibility, his responsibility. We all came up with all kinds of things. And they chose what they chose, and they came back pregnant. And they said, what happened? And, it turned out, in fact, one day she took the pill, the next day he took the pill. Back and forth. Back and forth. So, you do actually have to get all the way to shared meaning. I thought we were communicating. Thank you very much. Thank you. That's great. All right. So I'm a general internist. I see patients in the outpatient side, also on the inpatient side. And most of what I'm going to show you today is really about care transition, discharge information from discharge from the hospital to home. But really, it's true, and what you're pointing out by talking about after visit summaries is this is really true for all of the transitions from in the clinical setting. We also did a project from a post-discharge from rehab setting, so it's nice to see Avniel here who does stuff in rehab, and also in other kinds of settings, just in the clinic. But I hope that as people learn and touch different parts of this elephant, that we can share information and really expand together. Now, most of the stuff from Project Red comes out of a history of several years, really, of funding from AHRQ and NHLBI. And one of the things that really is easy for me to say is that there's no way for me to address all the topics here. And so one thing that really you could do if you want to learn more is to see a toolkit that we developed with the AHRQ. Cindy's sitting here. She was instrumental in the creation of the toolkit. And by going to this link, you can see a lot of the stuff that we were developing in that space. Another thing for me to say off to the start is because of the success of Project Red, Boston University Medical Center chose to implement a commercial license and to accompany engineered care, and I serve as a consultant to engineered care. So that's a conflict of interest statement. I want to try to move very, very fast to really focus on the topic for today, but there's a series of activities that we went through to develop in the end what we thought was, and to understand our own processes and to try to think about how to redesign them, to come up with what we regarded as the red checklist, which initially was 11 mutually reinforcing components. And right when we came out with it, it was adopted by the National Quality Forum and many other organizations. And then we went through a whole series of processes to evaluate this and to update it. And again, with work with Cindy, we made it into 12 components. And that was particularly in a project to evaluate and expand our thinking about cultural competence in the context of Project Red. And that was to add another step, which was to make sure that we were doing appropriate work with respect to language of support and assistance. So that was the step that was added. And when you do these projects, there's always more to learn. So for example, when we initially had done them, we didn't have as part of the process advanced care planning, but of course it needs to be part of it. Like it just was the limits of our own, stepping forward as we could. And as we've done other projects in other places, like in rehab facility near us, where there was an average age of almost 90, it was like, oh, of course there needs to be, advanced care planning as part of this story as well. Of course it is. So let me just bully on ahead. And the focus today is really actually to, as I understand it, is to focus on the written discharge plan that goes to the patient something that the patient can understand. And there's so many things to worry about for these documents. The moment you create them, they're out of date, right? So there's so many problems with that, and most of the way most organizations do this is as if it's a flat piece of paper, and it's out of date the second you did it, because you thought the patient was going to be able to obtain this medicine. Even if you talk to them, they might not be able to, and how that gets updated and all the time. And in fact, these things have to be live documents. They have to be, they really should be electronically available anywhere you go, on any device you touch, and it's crazy that we're not there already. So what I wanted to focus on, I have a few key messages that I would like to focus on. One is, you should not think about this as a form. You could think about this piece of paper, the discharge summary or the after visit summary, but I think that's misleading. It's a process, and in fact, it's a process that represents a significant cultural shift in many of the organizations that we think about, and what it would take to get to this place. The traditional format of this form really wasn't much in the service of the patient, and you can still see a lot of evidence of that because the forms are not easy to understand, and it's very easy. For me, there's many patient stories I can tell about failures in this space, or even from my family. My mother has a Ph.D., but she'll literally say, my son's a doctor. You just talk to him. I don't understand this piece of paper, because there's so many barriers. There are barriers all over the place. There's anxiety, there's cognitive barriers that were mentioned earlier, of course, literacy barriers. That's kind of my, the axe that I like to grind. But in order to change this to a different perspective, it actually takes a lot of work. You have to figure out how you can communicate to your personnel, to your whole organization, through and through, that you care not only about the work that they do with your clients when they're there, but also when they leave you. And that's actually a different type of focus, because there's so much work to do anyway. In the hospital, the lingua franca really is who's got the next hit, who's taking the next admit. And really to shift from that perspective to actually to say, I value the work that you do in preparation for this person to go home, that they can go home and succeed when they go home, that they're not going to, so that's actually a different space to be in, and it takes a lot of work to make this cultural shift. Now, many people have mentioned this already, that you put bad data in and you're going to get bad data out. And one of the problems with utilizing electronic systems is that they are full of bad data. They really are full of bad data. But it's because we're trying to change something that was used for one purpose and use it for another purpose. So if the clinicians use the med list as some kind of a memory device, 5 years ago I gave you amoxicillin, which is really, those are the things that you see on the med list. No one thinks that's actually what the patient is actually taking now, right? It's not an active med list. So there's all kinds of things that happen that you have to scrub out if you're going to use it for a new purpose. And there's many, many, many examples of bad data in and bad data out. And here's some comments about that. I think several people have mentioned already that the problem that you print this thing and it's got all kinds of confusing parts. And this is one of the observations that I think I can make from Project Red. If you, whoever you are, if you're responsible to take this document and go to the patient and the family and to teach them about it, if you're going to stand in front of them and actually teach them this information, then you're going to be invested that it's not full of garbage, that it doesn't have 4 lines for insulin in it or some other crazy things that just don't make sense. If you're physically going to go and teach that, you don't want to look like a fool, and you're going to it's going to be harder for you to do it if it's full of garbage. And if it says, amoxicillin from 4 years ago, it doesn't make sense. And you're sitting there saying, oh, no, let me cross that one out. That doesn't really, I know you weren't on that. So actually, you need people to be invested that the product is patient-facing, that is something that they can walk to the patient and actually do. And until you do that, people will not be invested to make the product work. And when I'm busy, my EMR on the outpatient side, my EMR prints an after visit summary. And on every visit where I haven't invested the time to actually make it worth anything, it prints automatically and I set it aside. I don't give it to the patient because it would be an embarrassment. It's not accurate. I would say probably most doctors are not giving those after visit summaries to the patients because they're embarrassments and they don't mean anything. Or if they do, you know, when you move the person off to long-term care, you'll find them in a big pile on the floor, you know, holding up some other pile of dust or something. That's what happens to these documents. In the end, the data that comes in has to be accurate, has to be up to date, it has to be comprehensive, tailored to this person's needs. MedRec, we could really spend a long time just talking about MedRec. It's a whole philosophy, actually. Most people in the hospital, they think that MedRec is to facilitate that the list from this doctor is the same as this doctor's list. But the patient has to get into the story. So at some point, the MedRec has to involve the patient. Or you're going to go and teach the list to the patient, and they're like, you know, I never actually take that medicine. And so these kinds of things, it's almost like, what do we mean by these terms? So I don't want to spend too much time on MedRec, but it's very, very, it's the most complicated aspect. Medications are really the most complicated aspect. So it's worth a whole conversation, but not going to happen today. So in the end, the question's going to be, what training is needed to get people who are working in your organizations to be able to do this, to care about this, to see that it's part of their work product, and to actually do right by it so that they will go to the patients and their families and to facilitate the training that's needed. And then really what supervision and monitoring is needed. There's no teaching that you can do, there's no training and you can do, and it's like set it and forget it. No, that's not how it works. You actually have to set it, you have to then monitor it, and you have to supervise it, you have to give feedback and say, oh, you know, actually you have 2 beta blockers on this person's discharge form that you just printed. Is that what you meant? I don't think so. Okay, so the next thing is another thing. It's not the form, it's the process, and that's on the, now I'm going to talk about the patient side of that. So I would say it would be incredibly cynical not to do a much better job with these documents than we do now. But no form will stand on its own. You need to engage the patients and the families with those documents. You can't just imagine that, you can't just magically hand them out and think that anyone's going to be engaged with them. You have to actually teach them. You have to, it's your responsibility. I think Bernie, I think you said, let's shift it to be, it's our responsibility, something like that. That one of the recommendations could be like, we actually have to hold people accountable to making sure that people comprehend stuff in this space. Did I make that up, or you said that? Oh, okay, all right. I'll take that. So, it would be cynical not to do a better job, but you can't imagine, oh, I made the form look nice, and so now it's going to work. And so no form will be understood by everybody. Every document that goes to a patient, every document, you have to say, what is my educational agenda with this document? How will this document be empowering and activating for patients? What is the educational process that's going to be needed to support this form or this document? And then, what training is going to be needed for my staff? And what supervisioning and monitoring is going to be needed in order for this to actually happen? And, you know, this really requires that we regard all of our institutions in a kind of a pedagogic purpose and a pedagogic role. And some people are better at that than other people. And so this is a process that needs to go through. And sometimes more people need more training or feedback about how it's important to you. And there are things about the forms that can be used, that the forms themselves can be designed for the purpose of facilitating a pedagogic perspective. So I'm going to show you some things about what we did with Project Red and take it from there. So to make this checklist, I think probably a lot of you have already heard this stuff, so I'm sorry if it's really boring. But to make this checklist, the Red checklist kind of operationalized, we created what we call the after hospital care plan. I've told this joke so many times, but maybe there's even just one person here who hasn't heard it. Right in the beginning, we called this the discharge plan. In the third focus group that we had, some guy opened his hand at the back of the room. Come on, so many people have heard this, but please, someone laugh, please. In the third focus group, someone raised his hand and said, this looks nice, I kind of like this project, but what part of the body is the discharge coming from? Oh, thank you very much. Okay, thank you. So good. So the thing is that like I'm really interested in ferreting out the jargon, but it took that kind of work. I mean, it takes interacting with your target audience. And Rima's comments earlier, completely apt on the, it takes doing stuff. You have to use this stuff with the target audience to see what people know. And it took a while for me to realize this shouldn't be called a discharge plan. It's a care plan. In this context, after hospital care plan, or it could be a care plan in any other context. So we created a new role, which is called a discharge educator, which is a nurse who actually facilitates the checklist. And when we started this checklist business, people said, there's no way anyone's going to do any of this checklist business, checklists, but that was like a decade ago now. And now you can literally talk with people in normal conversation and say the word checklist without them laughing at you. But I'm telling you, at the beginning of this, they said, maybe nurses will do that, but don't let don't say checklist, it's too demeaning. But now, actually, checklists are kind of on an uptick as an approach to organize complicated processes. And then we also, part of this, we also did a phone call follow-up for afterwards, because this is all complicated. This is kind of what the look was after we worked at this at different times. This included the patient's name and in different projects since then, it's evolved. So in some places, this actually has the goals of care right in the front in terms of the contact information for that. And in other places, we've had other adaptations as well. I'm going to show you some examples afterwards. This is the way the medications are set up. And by the way, when we started this was before the meaningful use requirements. And so I'll show you we had to adapt to bring it up to date for meaningful use requirements. Now, this is not the way to save a lot of trees. There's a lot of space being used for these concepts. But this is a way to actually facilitate that someone would use this to teach this information, because it's different enough. People are like, oh, this is different. And even with this, if you don't engage people with it, they just won't use it. They'll think it's like a memory test when you go to evaluate their comprehension. It also has appointments that are color-coded and associated with the calendar. It also has a page that has to do with developing your agenda for when you're going to go and talk to your primary care provider or your subsequent provider down the road. And here you actually have to take it out and have the patients writing with it, or if you can help, maybe you have to help them do that. But you actually have to get them to touch this. If they don't touch the thing, they're not going to remember any of it. So you actually have them to touch it, and you have to evaluate their comprehension of these things. It also includes some information about some of the conditions. And I'm going to bully on ahead for the sake of time and say that we did a trial, randomized people, 30-day outcomes, coming back to the hospital was our main outcome, intention to treat analyses, blah, blah, blah. And there was a 1/3 decrease coming back to the hospital for the subjects randomized to the intervention group. So that's a kind of robust effect for this whole thing. But here's another example. You actually have now going to have 2 speakers today saying good things about the VA. So this is actually from a VA implementation. There's now 6 VA sites that are using this in one form or another. It's integrated into Vista, so that you can get the medications and the appointments and the primary care doctors and their contact information and the diets and all this stuff coming out of Vista. I mentioned the rehab project. The rehab project was an instance where we were able to integrate this into Meditech and to have the medications come out and the appointments come out and stuff like that. And I can talk more about this if people are interested. This is kind of the reformatting look that the VA, working with VA folks, were how they wanted it. It looks slightly different, but it basically it has a kind of all the same categories of information. I think it was mentioned earlier that when you create these systems, and here you can see examples like one of the requirements is to identify which medications are new or discontinued and stuff like that. And that was not part of the original RED. That was not a requirement yet, but now that's part of the system to identify which ones were new and stuff like that. I think it was mentioned, I forget who mentioned it before, that when you create something like this, you don't know who all the consumers are going to be. You create it for, say, the patient, but in fact, actually, you get phone calls from like the visiting nurse and from somebody else in the primary care. The visiting nurse, like their biggest worry in the world is they're going to be in the room, they're going to be in the home, there's going to be a problem, and they don't know who to call. It happens to them all the time. And they call the primary care doctor who doesn't even know the patient was in the hospital, let alone discharged. And if any of you have ever been in this situation, it's not a nice spot to be in. And finally, if you have this information there, the visiting nurse is like, wow, I know who to call. I know what the medications are. This is awesome. They also, they have a requirement to create a care plan as well. And it's great for them to start with something that's been worked on and developed to be at least up to date as of the discharge. I'm going to try to show you some other things. Again, color-coded to a calendar. This is what the interface looks like. So in most of our implementations, we try our best to have as little data requirements as possible for the doctors or whoever's going to be loading the information to be putting in there. So most of the stuff goes in automatically. There are some fields that are notoriously poorly represented in EMRs. So I'm finishing in just a second. So notoriously motivated mentioned in the EMR, for example, you'd imagine it'd be easy to know if the patient's a smoker. Something like that actually is something that status changes all the time. And so there are some fields that in the end the clinicians will have to create. And then I mentioned before, it's very important to be able to know if you're succeeding at this stuff, to be able to generate reports, to be able to give feedback to people. This is part of an adequate supervision process, to be able to generate reports and to give feedback and find the places in the hospital or wherever kind of an institution you're working in where people are not doing what you think they should be doing. And you have to be able to figure out where to find them, how to find them, and give them feedback. And if you don't have the power to give them feedback, find someone else who has more power than you to give them feedback. Thank you very much.